download the file. Is that all right if I just have the one on,
What do you,
like,
oh,
and just pull it up there?
it'll have to be on this screen to show up there, just to let you know. But
Sure.
I guess, yeah,
Yeah,
I
okay.
should be able to
Sounds
do
good.
that.
And then
I'll leave that
wanna-
open.
It's out of the email.
It's not open yet. Do you wanna, or is this
That's open, so you just want to X out of that and then we'll just be ready. Thank you so much.
close that? Alright, I'll just minimize
Great,
that.
thank
I'm
you.
gonna close mine too.
I like this. So,
There we go. I got it. Yeah. Hello? Yeah.
Audience microphones are.
yes, yeah. So that I heard.
Yeah, no, what works. Especially for social media, for social media.
Yes. So I'm gonna do it.
Oh, sure, sure.
And also,
This one's off of this or off of this, but or off this.
let's see what that
Oh, or
does
that.
for a second, because it's, every once in a while they work, they don't always work.
And it was left on.
No problem.
I turned it off.
So I guess you can't wander as far as you'd like.
That's okay. It's this or this both.
You could use either one.
Okay, I'll do, yeah, that's good.
You want that? Yeah.
Yeah,
Let's see.
yeah, got it. Yeah, got it.
Still not working.
I'm okay with that because I may
Yeah.
use the arrow here anyway, so I think we're okay.
That's why this one doesn't work. Would you rather?
I think it may be easier,
Okay.
just,
Whatever you're comfortable.
yeah, it might be easier on that, just because I won't wander and I'll use, yeah.
Okay, but we can plug it in.
I think I'm, yeah, thank you so much.
Is the recording started already?
It started already?
Yeah, that's not.
I'll now check that. I should have asked way before. Thank you.
You guys hear me okay? Is that okay? Okay. This coming through okay? In the back? All right, thank you. Okay, well, thank you, everybody. I'm Dr. Brooks, one of the neurosurgeons here. I wanted to really, this is a very, very nice, actually great symposium. This is one of our first joint visiting professors, and hopefully not our last, where we've brought together two departments and really thought about the multidisciplinary care of neurosurgical patients, of spine tumor patients in this case, and as our guest, we have Dr. Mark Bilsky, who is just a wonderful man. We've spent the last 12 hours in various dinner events and tours and all those kinds of things. I've learned a whole bunch about him and his thought process about taking care of spine tumor patients and really kind of coalescing different different care opportunities for patients, I guess is the best way of putting it, and trying to make sure that the patients get the best opportunity for care that they can. So he's coming to us from Memorial Sloan Kettering out in New York, and is the chief of their multidisciplinary spine tumor service, which is its own service line, which is amazing because that means that they have enough business to really have to do that work in a very organized fashion. And I think what we're going to learn from him, he's spent a career building, and I think it's really going to be wonderful information, and certainly hopefully learn a lot more also when we're talking about case discussions. For the residents and maybe fellows in the audience, just please make sure to touch base with Dr. Bilsky, because he's just been really open, happy to talk about things, and would be a great person to learn from. I like to, before we get started, I was told we should give him his honorarium and his gifts first. So we have a few things here. Please come up if you would.
Oh, that's so kind.
Thank you very much.
You should really hear the talk first, because I don't know.
Yeah. I was told I better do this first in case people ask too many hard questions later. This says for you, but it's actually, as Dr. Dempsey would say, for your wife.
Brilliant. Thank you so much. Thank you so much.
And then of course we have a pen, a Wisconsin pen.
I love that.
But you remember we were talking about Dr. Trost, who retired.
Yeah, indeed.
And he gets he gets bored easy, so he started building guitars.
Oh, that's crazy.
Now, I asked him to build a charcuterie board, which he turned into a guitar, which is wonderful, and it's very well built, and it's all.
Oh my God!
It's kind of an interesting charcuterie board.
Yeah, indeed.
And we won't make you carry it home. We will.
Thank you so much.
But if you would, we got to get a picture especially for Dr. Trost.
Yeah, I guess you should hold it back.
Yeah, you can hold it out.
That's perfect. And if you look at the little brass thing pulled in there.
Oh yeah, it's really well built.
Oh, it's extraordinary.
Oh yeah.
Oh, that's very cool. Thank you so much. That's cool. I hope I live up to this. This is a lot of pressure now. I was just going to give a talk. Now I think I'm going to have to sing and dance too.
Thank you, and we really appreciate you coming. It's been a wonderful visit. Thank you very much.
Back at you, Than. Thank you so much and Brett, thank you for the invitation. I think we have just going to try to share this multidisciplinary effort we've had at Memorial now going on 20 years. And I think part of the difference from us and a lot of other spine surgeons that started out in this field was that we saw the utility of radiosurgery very early on and figured out how we had integrated it. And we did it really with no ego about it. We weren't really vested in being spine surgeons, and the radiation oncologists weren't vested in being radiation oncologists. We just came together to try to solve a problem that was very complicated. And what we're going to show you is sort of the evolution of what's happened over now the last really 25 years. And so hopefully this will be meaningful to you, especially because you have all of the components to build. You have the most extraordinary spine surgeons and the most extraordinary radiation oncologists here at University of Wisconsin. And now we just want to see if we can't consolidate that program for the benefit of the patients to expedite treatment and make it as effective as possible. And now I'm not sure what to do. There we go. So metastatic spine tumors are a massive problem in the cancer population, and we've seen an increased number over the past 15 years or so. Partly it's just an ascertainment issue that MR and FDG PET have improved detection, but also the systemic treatments have improved for survival. But the biologics and checkpoint inhibitors are much more effective for visceral than for bone disease. So we think we're going to see a continued uptick in the number of tumors that we're responsible for. And despite that improved survival, the treatment for metastases remains palliative. And if we get this kind of outcome of this patient doing this 100-mile paddle in this Whitewater River, having undergone separation surgery for an L3 mechanical radiculopathy, we've clearly done our job in palliation versus this patient who has both failed fixation and a radiation recall burn requiring extension of hardware and a free flap reconstruction. Everything we've done in the past 30 years is to mitigate this kind of outcome. We've been through three distinct periods, at least since I've been doing spine tumors. Up through the late 1980s, we had two treatment options: laminectomy without instrumentation and conventional external beam radiation. Laminectomy without instrumentation was a terrible operation. It created iatrogenic instability, deformity, progressive pain, and often neurologic decline. Conventional external beam radiation, which for the spine is often given as 30 gray and 10 fractions. A paper as early as 1978 from Gilbert Kim and my great mentor, Jerry Posner, showed that solid tumors were what they called unfavorable responders, or what we now call radioresistant. And despite those poor responses, conventional radiation was as effective as decompressive laminectomy and became standard of care. By the 1990s, the pendulum swung towards surgery with the development of segmental instrumentation, transarterial embolization for hypervascular tumors, and then the Patchell study 2005 showed that surgery was better than conventional external beam radiation for solid tumor malignancies. And with that, we began to see this proliferation of incredibly aggressive approaches, which were often not well tolerated in the metastatic population, including en bloc spondylectomy, even for metastatic spine tumors. The decision-making during this period was largely surgically based, such as the Tomita and Takahashi scores. We recognized that en bloc resection or aggressive resection wasn't going to be the solution in these patient population. It really wasn't predicated on our spine experience, but really with my first academic and clinical interests, which were really the skull-based malignancies. And we used to do these massively deforming surgeries, and yet it had no bearing on the outcome of that patient. In 2006, Ian Ganley published this paper that showed that if you had a low-grade tumor like an esthesio or maybe a low-grade sarcoma, the surgery might be meaningful. But for the most of the pathologies that we see in the nasopharyngeal cavity and really around the spine, mucosal melanoma, adenoid cystic carcinoma, squamous cell adenocarcinoma, it didn't matter how aggressive you were with the surgery. Bad biology and bad anatomy beats aggressive surgery, and we needed a better mousetrap. The other place we saw it very early on were in the superior sulcus tumor, the Pancoast tumors. If you did an en bloc resection of Pancoast tumor, the 2-year survival was 13%. Valerie Ruch at our institution led an SWG intergroup prospective enrollment trial using induction chemoradiation with cisplatin, topicide, and 45 gray radiation. And the 2-year survivals went to 55%. If you got a complete resection, it went to 70%. What it allowed us to do was, instead of being really aggressive, especially around the brachial plexus, where oftentimes Pancoast tumors will involve CAT1 and lower trunk, and we used to resect those and then give patients really significant hand intrinsic weakness. But once we got chemoradiation, we started to biopsy all on the epineurium. If there was no tumor viable there, we would just leave it. And so we spared hand function with induction chemoradiation followed by resection. And it turned out it was a very good strategy. 2023, we looked at the 155 patients we'd done over that time period with that protocol. And if brachial plexus was involved and we used that protocol, the local recurrence rate was 4%. So it's a very effective strategy. And again, it wasn't about the en bloc resection, it was about the response to chemoradiation. In the spine tumors, that transformative technology that was better than aggressive resection was really in the form of stereotactic radiosurgery. It's defined as high-dose perfection conformal photon beam radiation, often given a 16 to 24 gray single fraction or 24 to 30 gray in 3 fractions. And compared to conventional external beam radiation, the responses are both histology independent and ablative. And that fundamentally changed the indications for and type of surgery that we do. We can now give definitive radiation if we had a target with the expectation of durable tumor control. We could do hybrid therapy, separation surgery, or really simple decompression followed by radiation therapy to get control. And then we could do the minimally invasive stabilization procedures like kyphoplasty or Perk screws, again, with the expectation that we could control tumor with the radiation. With the integration of radiosurgery, the decision-making was mandated to become multimodality. At Memorial, we use a Noam's decision framework where radiosurgery is fundamentally the most important for tumor control, and we're now beginning to integrate proton beam radiation, and surgery is largely an adjuvant to radiosurgery for decompression stabilization. In the Noam's framework, there are 4 sentinel decision points: neurologic, oncologic, mechanical stability, and systemic disease to decide best treatment. It's an algorithm at any point in time, but we largely leave it as a decision framework so that we can integrate evidence-based medicine and new technologies as they become available. What it does for us on a very pragmatic basis is it takes this really complicated patient and pares it down to these 4 sentinel decision points. This is a very typical case example. You'll see this in your emergency room or in the hospital at presentation. 78-year-old male has stage 4 papillary thyroid cancer, BRAF positive. He had neck and mediastinal lymph nodes. He got a thyroidectomy and solumetinib with RAI. 2 years later, he developed back pain that was initially what we call biologic back pain. That's night or morning pain that gets better over the course of the day and simply denotes the tumor is there. That's the pain that responds to steroids. And then it became mechanical. It developed severe axial load and recumbency pain. He's neurologically normal. He had significant past medical history. His cardiac stents and COPD, but not requiring oxygen. His systemic workup showed on his PET scan that he has widespread bone disease and some pulmonary nodules. And you can see he has extremely high-grade cord compression at T5 with a plain and burst fracture and bilateral posterior element disease. So when you look at this, as when I was a resident or when I was a young attending, I looked at that and there was just too much information. It's like, how do I make sense of this and come to a really meaningful decision for this patient? If you break this down into knowns, patient has high-grade cord compression but is neurologically normal. From an oncologic perspective, the tumor histology is papillary thyroid cancer, which is resistant to conventional external beam radiation, but it's remarkably sensitive to radiosurgery. But at least at the time, we didn't think we had a target for radiosurgery with high-grade cord compression. The patient is mechanically unstable with a SIN score of 14. And then we go to the systemic disease. The SORG nomogram is a predictive model of survival, which gives us a 50% 1-year survival. And the medical clearance, he's an ASA grade 2 and puts him at moderate risk. So for this patient, if we take all that into account, high-grade cord compression with a radioresistant tumor who's grossly unstable and ultimately can tolerate surgery, we're going to take him for hybrid therapy, separation surgery, followed by radiosurgery. What NOMS allows us to do is disposition patients very quickly and make very consistent multidisciplinary decisions. This was a single week where we saw 120 tumors. These are 11 of those tumors. They have a myriad of issues that are complicated, much more complicated than what you see oftentimes in the degenerative or trauma population. And NOMS allows you to take this vast array of problems and consolidate them into a single decision framework. In terms of putting our multidisciplinary clinic together, our group started in 2007, really with the integration of radiosurgery, and NOMS helped everybody get on the same page. Our radiation oncologists had to understand that there was an instability issue. The neurosurgeons and interventional radiologists had to understand that there were differences in radiosensitivity, and NOMS allowed us to come together as a group. And then as we've grown out over the years with over 35 providers in our program, it allows us, this entire group, to make very consistent decisions based on the NOMS framework. In terms of practical applications on a weekly basis, we do tumor board, which I think is super important, keeping patients, providers who have really significant questions that we can answer them in a group discussion. And we do a Tuesday contour review that's webcast for radiosurgery. The strength of the program really is in our 5 multidisciplinary clinics a week. So we have at least 4 of the different services: neurosurgery, radiation oncology, IR, rehab, and pain in the same clinic space at the same time. And it allows us, again, to make very consistent and expedited decisions for these patient population. At one time, the patients who came in, if they come in for a neurosurgery evaluation, ends up being radiation, they just sit in the same room and the radiation oncologist comes in. And so we expedite that treatment. If you delay treatment in this patient population, so you have a patient who gets a neurosurgery appointment and ends up being radiation, and they don't get that appointment for 2 weeks, all of a sudden you've delayed it and they upstage, right? It's not like a trauma where you have this fixed deficit when they come in. It is that their tumor will continue to grow or they'll fracture in the interim. And so it's very important to get them expedited. Now, we have the luxury of doing that because we're in a cancer hospital and we have an inordinate number of patients to see. What really is important in this paradigm is that you have providers who are readily available and can expedite treatment. So even if the radiation oncologist and the surgeon aren't in the same room, if that patient comes in to see the radiation oncologist, comes in to see Brett, and it's not his problem, they have to have the ability to get very quickly to neurosurgery. And so in some way, you have to expedite that even if you're not in the same space. The other thing that being in the same space helped was that we had 5 different services looking at the same patient at the same time. And we saw our successes and failures almost in real time, and we could troubleshoot those in real time. And you can see as we go along how we sort of changed our practice based a lot on what happened in this clinic and what we all saw together. I think the other thing that's super important when you start to consolidate a program is to have a single spine triage number. So your providers, your medical oncologist or your your internist who picks up the fact that you have back pain and may have a metastatic tumor. You don't want them to decide whether it's radiation or surgery. You just want them to send into the system as quickly as they can and let us disposition the patient. So we have a single triage number. Any provider can call that number and get into the system very quickly, and then we'll disposition them for them. And typically we'll see patients who are non-acute within 48 hours. And if they're acute, they'll come into urgent care. And then in the hospital, anybody who presents with cord compression, we have a rapid response team really to get them to imaging right away and then disposition them to treatment. It's a very effective strategy for keeping patients out of trouble. So how does NOMS actually work? The neurologic and oncologic considerations are made in combination. And from a neurologic perspective, we're very concerned about myelopathy and functional radiculopathy, but much of the decision-making is based on the degree of epidural spinal cord compression. There's a scoring system that's been validated. It's in the literature a lot. It's called the Bilsky score. It's kind of nonsense. It's just my name was first on the paper, but it's actually remarkably good at assessing outcomes and what you're seeing. And at least at our institution, our radiologist will actually put the ESCC score on the read. So you have an idea of what that looks like when you go to see the patient. In the ESCC score 0 is bone only, 1 A, B, and C are different degrees of epidural impingement without spinal cord compression. 2 is spinal cord compression, but CSF seen. 3 spinal cord compression, no CSF seen. And for decision-making purposes, traditionally the 2s and 3s have been considered to be high-grade cord compression. From an oncologic perspective, what we're really talking about is how we achieve local tumor control, which at least to us is completely predicated on the radiation response. Radiosensitivity has been completely redefined as we've transitioned from conventional external beam radiation to radiosurgery. Now, there are radiosensitive tumors still to conventional external beam radiation at 30 gray and 10 fractions. The hematologic malignancies, lymphoma, myeloma, and then the hormone-driven solid tumors, breast and prostate, are relatively radiosensitive. The remainder of the solid tumors are largely radio-resistant with median durable responses of 3 months and 2-year local control rates of only 30%. Here's a patient with multiple myeloma, 3-level high-grade cord compression, presented Asia C. We put this patient on high-dose steroids, gave 30 gray and 10, and you can see the 10-day follow-up film, the tumor completely apoptosed, decompressing the spinal cord, and in this case, recovering the patient to normal neurologic function. There is now evidence, class 1 evidence, in solid tumors that SBRT is better than conventional external beam radiation. This is the Canadian clinical trial group symptom control that Arjun Segal led. And in this series, patients who got radiosurgery, 24 gray and 2, did significantly better than those getting conventional external beam radiation, 20 gray and 5, in terms of local tumor control and the need for reirradiation. What is really interesting in this is that about 70% of the patients were actually remarkably radiosensitive to conventional external beam radiation, including a lot of breast and prostate, and there was still a significant difference. And for those reasons, for the most part, patients with minimal or no spinal cord compression with radio-resistant tumors now go straight to stereotactic radiosurgery. Here's our initial series of a little over 800 tumors, principally with radio-resistant tumor histologies, where we had a definitive target for radiation with ESCC score 0 to 1C. Contours were according to Radiosurgery Consortium guidelines. There were 2 dose cohorts. The median dose of planning target volume, the low dose cohort was 16.4 gray single fraction versus the high dose cohort 22.4 gray. The only factor significant in the instance of goal failure was the dose of radiation, but even in the low dose cohort at 16.4 gray, we only had a 5% failure rate at a year, increasing to 20% at 4 years. In the high dose cohort, it is ablative. At 12 months, we had a less than a 1% risk of recurrent of failure versus at 4 years, it was only 2.1%, right? We overcome radio resistance with high dose perfraction radiation, and these responses become both histology, at least we thought, and volume independent. More recently, we looked at a large series of a little over 2,700 tumors where we not only looked at the single fraction radiation, 24 gray, but also the high dose hypofractionated radiation, 30 gray and 3, and 27 gray and 3. And it turns out, as we expected, 24 gray single fraction is still better than 3 fraction radiation. What we didn't necessarily expect was there's also a significant difference between 30 gray and 3 and 27 gray and 3. And so for the hypofractionated radiation, our institution, most of them will now get 30 gray and 3. The other thing we did not expect was there actually is a histology dependent response. And so we've always said that this radiation is ablative and it overcomes radioresistance for every tumor histology, but it turns out that breast and prostate do significantly better than non-GI solid tumor malignancies. And for some reason, the GI malignancies, colorectal, cholangiocarcinoma, hepatocellular do worse. And we're now looking at mechanisms of radioresistance in that group. And it doesn't matter what fractionation schedule you use, whether it's 24 gray or high-dose hypofractionated, those histology-dependent responses actually are consistent. Much of the past, really 20 years now, has been used to define dose constraints for organs at risk. And the most important is obviously the spinal cord. And at a core Dmax of 14 gray single fraction, we have less than a 1% chance of creating myelitis. But it's that cord constraint that prevents us from treating high-grade cord compression with single fraction radiation, because either we'll give an ablative dose at the margin of the cord and create radiation myelitis, or we'll underdose at the margin of the cord where we need the greatest control and potentially risk epidural progression. And so traditionally with single fraction radiation, we have not treated high-grade cord compression. This series convinced us, however, that we can use hypofractionated radiation, that 3-fraction regimen. We improve the therapeutic window, right? We're willing to take a little less tumor control, but be much safer around the spinal cord. And it turns out with a 3-fraction radiation, that it doesn't matter whether they have that definitive target 0 to 1C versus 2, 3. It's a safe target. We have no increased morbidity from the radiation, and the local tumor control is the same. The question became, what about the need for separation surgery for high-grade cord compression with radioresistant tumors? And we looked at this series that underwent separation surgery followed by 3-fraction radiation versus SBRT only. And there is a difference. It's not quite significant, but it's about a 15% difference. It's between a 6.4% failure rate at 2 years versus 20%. But it gives you the leeway, and that older sick patient who's not going to tolerate surgery, they actually do remarkably well, even with high-grade cord compression with radioresistant tumor. And this is a big paradigm shift for us and maybe for most of the people who do this around the country, because traditionally we've told people you cannot treat high-grade cord compression with SBRT, with hypofractionated radiation. So this was a recent patient that we saw after we got this data back, 82-year-old Parkinson's disease. Spine biopsy was follicular thyroid carcinoma, and you can see he's got grade 3 compression, but neurologically intact. Follicular thyroid, as we said, is sensitive to SBRT. The SIN score, despite that degree of vertebral body replacement, was a 4, so they're basically stable. The Sorg nomogram gives him a 1-year expected survival. The problem is he's a huge medical risk. He's 82 years old, and he's got Parkinson's, and that's a really bad gig for surgery. So we took him for a myelogram CT for simulation, and he actually decompensated, but not from a motor standpoint. He just got increasingly bradykinetic for whatever reason from his Parkinson's. And so we went ahead and irradiated him. At the 2-week mark, the bradykinesia wasn't getting better. And so he said, oh, we'll go re-image him because if he still got compression, I'm just going to take him to surgery. I don't know what's going on. The family was really angry. So we gave 10 gray times 3. We re-imaged at 14 days, and the epidural tumor is gone. The tumor is treated, and we did not expect that. And so more and more, even the high-grade cord compressions in patients with radioresistant tumors who aren't candidates for surgery, we're now taking them for hypofractionated radiation. The problem is, if you're going to take it on as a radiation oncologist, you have to do it in a very timely fashion. So you have to have an expedited plan, and then you have to get them to treatment within a week, because again, these tumors will progress if you don't get them treated. And so more and more, again, in that older sick patient, it may be your bailout not to have to take them to surgery. We're looking at other strategies to improve the ability to give ablative doses to the tumor within the constraints of normal tissue tolerance. There is very good experimental and clinical evidence that VEGF TKIs in combination with radiosurgery act as radiosensitizers for renal cell carcinoma. We like the combination of SRS with superoxide dismutase mimetics, which give, again, the ability to give an ablative dose within the constraints of normal tissue tolerance. We had a 3rd generation superoxide dismutase mimetic that got pulled from the market. We're super interested in that strategy. And then immune modulation, the combination of stereotactic radiosurgery with checkpoint inhibitors. We know about the abscopal effect where we give local radiation and get a systemic disease response, but it can also augment local tumor control with smaller volumes of tumor treated. So here was a patient with renal cell carcinoma, irradiated twice and failed, had this massively growing tumor that was incredibly painful. We couldn't irradiate the entire tumor volume because the skin was dusky. And so Josh Yamada wasn't willing to give up on the patient and only treated the middle core of that tumor, 27 grade 3, and they were maintained on dual checkpoint inhibitors, Nivo, Ipi, during the radiation. You can see at a month the tumor necrosis, and by 2 months the DCE images show the tumor is dead. And so more and more we're starting to employ these types of strategy on protocol. The problem is, at least to date, we think even with these strategies, even if you get a response, you're not going to get an immediate effective decompression of the epidural tumor, at least so we think. And so to date, even though we can stay within the constraints of normal tissue tolerance, et cetera, we're not really aggressively using this for epidural disease. And of course that changed now because we have this hypofractionated data. But for the most part and around the country still, patients with high-grade cord compression with radio-resistant tumors go to surgery followed by radiosurgery. This is still largely predicated on the Patchell study published in 2005. It's a prospective randomized trial of solid tumors with myelopathy comparing surgery and conventional external beam to conventional external beam alone. And in every outcome variable, surgery was better than radiation. And based on that and a number of other studies, the spine oncology study group made a strong recommendation that patients with high-grade cord compression due to solid tumor malignancy undergo surgical decompression stabilization followed by radiation therapy. The question became, right, what kind of surgery and what kind of radiation? With the integration of radiosurgery as a postoperative adjuvant, the surgical goals of spinal cord decompression for neurologic salvage and using screw rod systems to provide mechanical stability remain the same. What changed, right, is the oncology. How we achieve local tumor control, again, is completely predicated on the radiation response. So when we use conventional external beam radiation as a postoperative adjuvant, it kind of made sense to do maximally cytoreductive surgery or even on block. With radiosurgery as a postoperative adjuvant, maybe the only goal has to be to reconstitute the thecal sac, to decompress the spinal cord to create a better target for radiation. And that became known as separation surgery. Here, an 86-year-old pathway thyroid cancer, HSC with 3-level vertebral body disease, I would submit to you there's no way to get this patient through a 3-level front-back surgery. Separation surgery is a very simple technique that most spine surgeons can do, even in community hospitals. Traditionally, we instrumented 2 levels above and below the index level. We take a high-speed 3mm matchstick drill and drill off the lamina, superior and inferior facet joint, and pedicle flush the vertebral body. We strip the tumor from normal dural planes, and then we cut the anterior longitudinal ligament across the anterior dura to affect a margin in that plane. And from a posterior only approach, you can do a very effective circumferential decompression. And at the end of that, you can ultrasound to make sure you've decompressed the spinal cord and created a target for radiosurgery. The goal of separation surgery is not to take out all the tumor, but simply to decompress the spinal cord and reconstitute the thecal sac to create a better target for radiation. Why do we like separation surgery for metastatic? They're very short operating times, 2.5 hours. We can do emergency operations for epidural tumor in the middle of the night without the need for an approach surgeon or the incumbent morbidity of anterior approaches in the metastatic population. And we can do these large volume, multi-compartmental tumors where our only real obligation is to take out tumor within that blue circle and create a target for radiation. And ultimately, for the spine surgeons, we do a better and safer epidural decompression because we always know where the spinal cord is. If we come from an anterior approach, you have to come through all this tumor and hope you find the dura before you're in it. If I come from a posterior approach, I always know where that tumor is and can strip it off the dura. And if you get a lot of bleeding in the tumor, you know where the spinal cord is and you can tamponade the bleeding away from the dura. In terms of approach morbidity, one of the hardest areas to reach is at C12. The best approach for that in tumors is a transmandibular osteotomy where you cut the mandible and come peritongue through that region. Here's the 12th nerve. This was in a chondrosarcoma. The problem with this in the metastatic population is they have to be pegged and trached for at least 2 weeks after the surgery, and that's a lot of morbidity in the metastatic population. Here we actually put a cage anterior, which was kind of foolhardy because all of the load comes through the posterior columns at C1, C2, and then at 7 years we were looking through his mouth at the cage and had to do a formal pharyngeal reconstruction. That's in counter-distinction to this patient. She's 33 years old. She had multiple fibroids resected. She was 3 months pregnant and tripped on an airplane jetway and was acutely quadriplegic and came in with this really large tumor at C2 with this large parapharyngeal mass. We did emergency separation surgery. So we didn't do that transmandibular osteotomy. We just decompressed her from the back and then occipital-cervical fixation. By the grace of goodness, with that operation, she went from plegic to normal neurologic recovery by a month, which was a miracle. It was just, she was young and healthy otherwise. And it ended up being a low-grade uterine leiomyosarcoma. So one of those fibroids they had resected was sarcoma. At the time, we gave adjuvant conformal photon beam, 66 gray and 33 fractions, so sort of conventionally fractionated sarcoma dose. Now we would have given IGRT or proton beam, hypofractionated 30 gray and 3 fractions. The baby was born about 3 months after the injury. Here's the tumor that we left behind after separation surgery that got her neurologic recovery. Here's an 18-year follow-up film with no evidence of residual recurrent tumor. It's not about the amount of tumor you take out. It's about the response to radiation that gives you durable local tumor control. Here's a 54-year-old female, the high cervical myelopathy, clumsy hand syndrome, needle biopsy. We knew this was chordoma, not an en bloc candidate. She's got high-grade cord compression with bilateral vertebral artery involvement in this large paraspinal mass. We took the patient for simple separation surgery to reconstitute the thecal sac, but left all that tumor on the bilateral vertebral arteries in the parapharyngeal space. We gave 24 gray single fraction. Here's a 7-year follow-up film with no evidence of residual recurrent tumor on standard MR imaging. Improvements to separation surgery. Traditionally, we went long segment fixation, minimum 2 above, 2 below the index level, in part because we wanted to distribute the load in what is often found in these patients, which is osteoporotic bone. And oftentimes, if they progress disease, it was adjacent segment, so we could account for that with a longer fixation. Over the past 7 or 8 years, we've now gone to short segment, cement augmented fenestrated pedicle screws, single level above and below the index level. We cement the screws in so we overcome right osteoporosis and potential adjacent segment progression. And our fixation failure rate in both of those constructs is about 2% in this population. So it's a very effective strategy to try to make this as small as you can, as small a footprint as you can to decrease the morbidity in these patients. We talked a little bit at lunch about peak carbon fiber, which is the newest and really the only instrumentation developed with tumor in mind. Compared to titanium, the durability we found is about the same. The big benefit is in imaging for recurrence, which is better with peak. And then in radiation, if you're doing an MRCT simulation post-op, there's this distinct advantage at defining the spinal cord. In terms of delivery, at least in our own institution, using VMAT, we don't have a big issue with photon beam delivery, but your big benefit is obviously going to be with protons and carbon ions using peak carbon fiber. And it's almost incumbent to put it in if you're going to go to those strategies as a post-operative adjuvant. In terms of titanium hardware, and again, it's been used for decades, what you don't want to do is build a construct that you would use potentially in deformity. And this was a patient who had T1-2 fractures that came into an outside institution. And I think most of you would look at that and say biopsy kyphoplasty, but they ended up with a T10 to the sacrum fusion. Be that as it may, my problem isn't actually any of that. If you tolerated that, it's fine. The problem is they put their dual rod construct over the canal. So we have that titanium artifact. And the titanium expandable cages have a big, thick ring that really puts a shadow across the canal. And so it's very difficult to see the canal. And so essentially, we lost all imaging through that segment. The other issues with this, just for the surgeons, is they had dish and they ended the construct below the dish. So they fractured there and then got a pannus. And then we were trying to figure out what was going on in that construct with the neurological progression. Now, you can do a myelogram for that, but it's a lot to put patients through. And so if you're going to use titanium, just be super aware to keep if you're going to use a dual rod construct, keep it outside the canal. And I would avoid using the titanium expandable cages, mostly because of that ring artifact. In terms of anterior reconstruction for us, for most of the metastatic patients, if we have greater than 50% vertebral body resection, we just put cement into that gap as an open vertebroplasty. And that construct works remarkably well. And again, if you're going to use a cage, probably incumbent to use peak carbon fiber. This was a Ewing sarcoma that got VAC chemotherapy with a magnificent response. And then we resected the tumor, the muscle, the facet joint, and did a sagittal osteotomy through the vertebral body and put a peak carbon fiber cage in with peak screws behind. And again, you can readily see for recurrence. This patient had a positive cell in the vertebral body margin and went to proton beam. So we were already prepared for that because we had peak in that patient. We're using more and more minimally invasive techniques, certainly a lot of perk screws, but certainly for the decompression, on occasion, we're using minimally invasive techniques, particularly for things like mechanical radiculopathy, where your real goal is to take out the joint and pedicle. It's pretty tailor-made for that. In terms of separation surgery performance status, 75% of our non-ambulatory patients regain the ability to walk, and overall 90% are ambulatory. In terms of patient-reported outcomes, patients do significantly well in terms of pain right now and general activity. In terms of local tumor control, if you do really aggressive surgery followed by conventional external beam radiation, the local control is only 30% at a year. Why? Because you're not going to overcome radioresistance. So tumor histology is the bigger predictor of recurrence. Here's our initial series of separation surgery followed by radiosurgery, or what we now call hybrid therapy, in 186 patients. Most were operated for high-grade cord compression with radioresistant tumor histologies, and 50% had failed prior radiation. There were 3-dose strategies: high-dose single fraction, high-dose hypofractionated, and low-dose hypofractionated. The 1-year cumulative recurrence was 16%, but if we gave a high enough dose single or high-dose hypofractionated radiation, we had less than 10% recurrence at a year. And again, there's no association, at least we thought at the time, with radioresistant tumor histologies. You overcome radioresistance with high-dose perfraction radiation. More recently, we've looked at histology-specific progression-free survival using separation surgery, followed by a median dose of 8 to 10 grade times 3. For renal cell carcinoma, our 2-year progression-free survival is 92%, non-small cell lung cancer 95%, and again, colon cancer does a little less well at 87%. We looked at mutation status. The patient had an EGFR mutation, was treatment naive. There was a 50% improved overall in progression-free survival, and for colon cancer, APC was a negative prognostic mutation. Now, we've talked about high-grade cord compression and separation surgery, or potentially even going now just to hypofractionated radiation. What you see here, I think not infrequently, which in a cancer hospital without an emergency room we see less, is that patient who comes in with myelopathy and a newly diagnosed tumor. So you have no idea, they have no known primary, and they come into your emergency room. And there are two camps that are really, so this is a case example. This is a 53-year-old football coach who presented with high-grade cord compression, significant myelopathy, Asia C, with low extremity weakness and numbness requiring ambulation with a walker. You can see this T10 vertebral body disease with 2-level high-grade cord compression. Two camps, right? One is biopsy and wait because histology matters. Because if it's hematologic, show that response in myeloma, potentially you could do conventional external beam radiation or even systemic therapy. For solid tumors, we've made the argument for separation surgery, and there's still people who would argue chordoma, that the only way to treat that is with a non-block resection. We're in the other camp, which is take them for emergent separation surgery and get them out of trouble. Histology doesn't matter, and you want to prioritize neurologic salvage. Why? Because time is spine, and recovery is predicated on time to treatment and the severity of the deficit. And what we often see, even on high-dose steroids, is they'll come in as an Asia D one day, and then you biopsy them, then you wait 1 day, 2 days, 3 days. You're not getting a biopsy back for 4 or 5 days. And during that time, they don't gradually get worse. They do what we call fall off the cliff. They go from an Asia D to an Asia A in a heartbeat. And there's probably a lot of reasons for that, but you don't want to sit on a patient waiting for a biopsy and have them become paralyzed on you. Because once they're in Asia A, there's a very short window potentially to get recovery, and most of the time it doesn't happen. So what if it ends up being a hematologic malignancy, which we said, you know, that you potentially could do radiation? They're exquisitely radiosensitive. The problem is it's very hard to make a definitive diagnosis in a timely fashion in these patients. So this was a patient who came in. This looks like lymphoma. This is sclerotic bone disease with a lot of soft tissue. 100 days to Sunday, that's lymphoma. And we biopsied it, and there were small blue cells. And our pathologists, who are best in the world at calling frozen sections, called it lymphoma. And we irradiated 20 grade and 5, which is an equivalent of conventional external beam radiation. 2 days later, the flow cytometry came back. It was definitively not lymphoma. And then it wasn't until 10 days later that we got a high-grade, poorly differentiated malignant neoplasm favored neuroblastic tumor. We had irradiated that patient with the expectation that we could decompress them with radiation. And in point of fact, we didn't. Now, by the grace of goodness, this patient was not myelopathic. And so we stabilized that disease. But if it had been myelopathic, we would not have decompressed the spinal cord or gotten recovery of function. The second issue is that even in lymphoma and myeloma, most of the myeloma patients that come in with neurologic are also going to have unstable fractures. It's the most osteolytic disease we know. But lymphoma also will often come in with a lot of soft tissue disease. And when you have circumferential disease in lymphoma and you irradiate it, they get this apoptotic response that is massively inflammatory. And we haven't done it in our institution, again, because we don't have an emergency room, but we have had patients transferred in that got irradiated. And then within an hour or two of the radiation, they're paralyzed. They have this massive inflammatory response. There's nowhere for them to swell. This pattern of disease is really complicated in lymphoma. And so for those reasons, we sort of justify taking patients, even if it ends up being hematologic, get them out of trouble and then get them to appropriate treatment. Then for myelopathy, it can be hematologic. We've defended that, right? We don't want them to fall off the cliff, and it's hard to make a definitive diagnosis. For metastatic tumor, we've argued separation surgery, and then it comes down to primary tumor chordoma. And it has been noted or argued that it's standard of care for chordoma to en bloc resect them. It never has been. It's just a philosophy that some people have that that's best management. En bloc is technically difficult, if not impossible, in the emergency setting. And in the setting of high-grade cord compression, you can't do an en bloc wide resection that would be curative. The bigger issue is that the data supports, A, that en bloc resection with or without low-dose radiation actually has incredibly poor local control rates and prohibitive morbidity. And when you add high-dose radiation, which would be defined as a BED greater than 70, so 24 Gray single fraction for chordoma has a BED of 150 Gray, it provides better local control, less morbidity when used as even definitive radiation or as a post-operative adjuvant. So if we go back to that patient that I showed you, that T10 with high-grade cord compression that came into an outside institution, Asia C, they very appropriately did not biopsy it and took it for separation surgery that got him neurologic recovery. The tumor came back chordoma, and they called us up and they said, "I'm so sorry, we did not block a chordoma." And our response was, "Thank you so much for getting them out of trouble. We'll take it from here." They did a great decompression to get neurologic recovery. We like 24 Gray single fraction for chordoma. So we went back and re-decompressed to give a better target for the radiation. And then this is an excellent construct in the metastatic population, 2 up, 2 down, but it's not going to be durable without a vascularized bone graft. So we took them back and re-instrumented with a dual rod construct outside of the canal. And then we did a vascularized road graft and turned it posterior lateral. We gave 24 Gray single fraction. Here's a 5-year follow-up film with no evidence of residual recurrent tumor on standard MR or DCE imaging. Here's our series of chordoma in the mobile spine. If we had a definitive target for radiation, we simply irradiated them. If the patient had high-grade cord compression, we initially started out with curettage, gross total resection, and then as we got more comfortable, we went to separation surgery. The bottom line is they got 24 Gray single fraction. Our 5-year local control was 90%. There's an AO mobile spine series that defined the role of en bloc resection for almost a decade, and it's really not a great study. But what the curve that they drew was that if you did an Oniken appropriate resection, which would be en bloc for marginal or wide margins, they did significantly better than en bloc or curettage intralesional. And this was used to justify en bloc for since it was published in 2016. What we showed was that with the addition of high dose radiation, you pull that Oniken inappropriate curve, which to us is definitive radiation or separation surgery, below the en bloc curve. We're not the only ones who have seen this. This is the MD Anderson series. It was a mixed series of chordoma chondrosarcoma using 24 Gray single fraction. They got the same number we did, 5-year local control of 90%, the low complication rate of 23%. And then UPMC showed the same thing with a little lower dose strategy, 2-year local controls. It's definitive radiation, 83% as a post-op adjuvant, 80%. These tumors are exquisitely radiosensitive if you give a high enough dose radiation. Here's our updated series, which will be published as a multi-institutional, but this is the data of chordoma in 77 patients treated with single fraction radiation in our institution at 24 Gray at a median follow-up of a little over almost 6 years. And a 24 Gray single fraction, once you get control of that tumor, it seems to be durable. So at 10 years, our local control is 88%. And it doesn't seem to matter whether you do it as definitive therapy or following either separation surgery or en bloc. And so we're hoping that these strategies change over time, that we stop doing these massively, again, disfiguring operations like we did in the cranial base, and start to integrate meaningful radiation to this patient population. And it turned out, we went to the Cordoma Foundation meeting in Milan, and the people who are wedded to en bloc were vicious. I mean, they were, I don't want to say abusive, is not the word, it was crazy, because we had all this new data in the last 10 years. There have been, in the last 5 years, there are 10 papers that show a radiation benefit, and yet they wouldn't do it. But when they actually publish the algorithms, which are now 2 weeks old, in conventional radiation, even if you do an en bloc resection, if you don't think you can get an R0 resection, meaning a wide margin, the recommendations for neoadjuvant radiation, if you do an en bloc with an R1 resection, you definitely need post-op radiation. But even if you do an en bloc R0 resection, en bloc wide, the recommendation is still to heavily consider radiation. What is new is the other side of that, the unresectable, which could be for any reason, age, high-grade epidural. They're now recommending definitive radiation and separation surgery, and that's new. And so if you see that patient who's got high grade, don't stand on ceremony and say you have to unblock a chordoma. You do not. And it's now supported by the Cordoma Foundation. The other thing that the sacral guys are more advanced than we are in how they think about radiation. So even in the resectable cases for the high sacral tumors, S1 to 3, where you're going to lose bowel and bladder, you can do either en bloc resection or definitive radiation. And the vast majority of orthopedists in the country who are the most aggressive with en bloc resection are doing radiation only. They're no longer doing en bloc resection for the high sacral tumors, including in our institution. And our institution ended up being the biggest in the country by far. We published a series of 119 patients, and I can show the data later if anybody's interested, but essentially definitive radiation did better than en bloc resection and as well as en bloc plus radiation. It's about the response to radiation in these tumors that's now defining the outcomes. So we talked about the neurologic and oncologic, right? The separate assessment is mechanical instability, fracture-related pain. Why? Because no amount of radiation will stabilize an unstable spine. The SINS criteria was developed to define instability in the neoplastic setting. There are 6 criteria which are weighted by their contribution to instability. Pain is the only clinical symptom. The rest are radiographic correlates. 0 to 6 is stable, 7 to 12 potentially unstable, and greater than 13 unstable. In those patients with painful bursting compression fractures in the thoracic and lumbar spine, they're very good candidates for standalone kyphovertebroplasty. And there is class 1 evidence from the CAFE study that kyphoplasty is better than best medical management at a month, durable out to a year. What we were really interested in is who fails kyphoplasty. And we recently looked at 445 patients. There was a 10% risk of failure, including, and the risk factors for that were kyphotic angle, a SIN score greater than 10, spinal canal compromise, and the big one for us was posterior element disease. If you have a burst or compression fracture and a joint fracture, you cannot do standalone kyphoplasty. You have to give them a posterior tension band. And we have seen that before. This is a patient with a T10 plane and burst fracture and posterior element disease. We do kyphoplasty and then percutaneous cement augmented pedicle screws at the adjacent segments. And in our initial series of those patients, they did significantly well again in terms of pain severity, going from severe to mild or none. And this construct in the cancer population appears to be really durable with 5-year failure rates of only 2%. So we use it fairly liberally. Again, in patients with a plane and burst or compression with posterior element disease, you need to give them a posterior tension band. Then there are patients like this with a C1-2 fracture subluxation, which you can see here. We don't have percutaneous procedure for that. That's an open occipitocervical fixation with a C1-2 decompression. However, more and more, we're trying to get away again from these maximally invasive surgeries. And the C1-2, we see a lot of C1 lateral mass fractures, and they have pain for 2 days, severe neck pain, and then it sort of resolves. And what they're left with is unremitting occipital neuralgia. We used to take them for an OC fusion C1-2 decompression, and now we just ablate the C2 nerve root, and about 80% of them get better without the need for further surgery. And then the sacral insufficiency fractures are a huge problem, and those patients are bedbound for 6 to 8 weeks while it heals. They cannot rotate, can't sit up, stand. We now do dorsal branch ablations, L4-5, and cluneal nerve ablations. And those patients, literally, most of them can get up and walk the next day. You just denervate the sacrum and get them up and get them moving. And so there are lots of strategies in that domain. I don't really worry about sagittal imbalance unless it defines the problem. And one of the places we see it, and if there are any head and neck radiation people here, you often see that sternocleidomastoid, you get that fixed deformity. And a lot of them are trached, and so it's a really bad problem because they end up like this. And this patient came in and he was absolutely miserable because when he was up walking, he was looking at the ground and couldn't interact with the world. One of the ways to deal with fibrosis is we just inject them with Botox to release the muscle and then pull them back into alignment. And then we did an occipitothoracic fixation. This is a terrible fusion for them. They are fixed in a halo. They can't flex, extend, or rotate. By far the happiest patient I've ever had. He's got his relationship back with the world and he's super happy, even though we've limited him. And then, you've gone through this NOM and you've decided you need surgery, you need radiation. The final assessment really was, does it make any sense in the context of the disease? Can they tolerate it? What can you do? Oftentimes survival is used as a predicate to determine whether you should do an intervention. And when we had chemotherapy, we knew almost to the day when people were regressed. And then we entered this era of biologics and checkpoint inhibitors. And whereas the medical oncologists used to be the most nihilistic people in the world and said, don't take anybody, all of a sudden they were take everybody. And so ultimately what you needed was a metric, right? To at least have some kind of an objective measure of what their expected survival was. There are two predictive models of survival that were developed in the era of biologic and checkpoint inhibitors, the SORG nomogram and the New England Metastatic Spine Score. They're online, they're super simple, and they at least give you some metric, especially in the short survivors, of who you should take or potentially not take. The other thing you need is, right, this is an older population in general, is a medical assessment. They have heart and lung issues. You need to make sure that if you're going to take them, they can get through that surgery. We had a PE death in a young physician. And we thought that should be a never event. And so we screened a number of patients to try to get a risk factor for that. It turned out that if the patient's non-ambulatory, even for a week, there's a 24% risk of occult DVT. And in those patients, we put a filter in them and then we put them on full anticoagulation 2 to 3 weeks after the surgery. Do you need to do it on patients who are fully ambulatory? It's still 6%. We actually Doppler everybody. If we don't get it before, we do it immediately afterwards just to make sure that we're not going to have a PE death. And then sometimes I'm just wrong. I can't look at this patient. He was transferred in from an outside hospital. He was bedbound. He had fractured his hardware on one side and pulled out his screws on the other. So he was grossly unstable across cervicothoracic junction. And he had a drain in and he was just pouring blood out of the drain. And I just looked at this. It's not really a hard fix, but he had multiple medical issues. Platelets were low, but I think it was because he was bleeding. It wasn't a coagulopathy. And we transfused him and held him. And I don't know if anybody's used it, but in the patients with low platelets, for a variety of reasons, there's now end plate, which you can use to stimulate their platelets. In this case, he actually responded to transfusion. The SORG nomogram put him at a less than 30-day survival, but I hate broken necks that you can't stay. This guy was wide awake and he looked fine. And so I took him, and the surgery was not hard. It took maybe 2 hours, right? Stripping out this tumor, this ended up being tumor and not blood. It was bleeding tumor, but stripping off the epidural space was pretty straightforward. And then re-instrumenting him didn't cost us anything, but post-operatively, he had about 4 good days. Then he ended up on a ventilator, DNR, and hospice. And so you're not always going to make the right judgment, but sometimes you have to make the call that you think is in the best interest, because if they get through it, there's a huge benefit. But you're not always going to make it, even though you're predictive. And I'm not saying take patients who aren't going to survive, but it's still a judgment issue on your part. And the last thing for the radiation oncologist, as you know well, is for oligometastatic disease, 1 to 5 metastases. There is now a significant benefit to radiosurgery in those patients. The SABRE Comet trial was the first trial to come out, randomized open label phase 2 trial, a European study, comparing standard therapy plus conventional external beam versus SRS to every oligometastatic lesion. And there was an overall survival advantage in the patients who got ablative radiation with SRS. And so now that local radiation actually has an impact on their survival. The PISA trial was our trial. It was a bone-only trial. 50% of those patients were metastatic, comparing 24-grade single fraction to 9-grade times 3. We knew there was going to be a benefit in terms of local control to 24-grade single fraction. What we didn't expect was a decrease in distant metastases. So now those small prostate mets that you would never have imagined imaging, if they're oligometastatic, oftentimes we'll irradiate them, trying to tap into this benefit. So in the NOMS framework as it stands now, there's still a role for conventional external beam radiation with radiosensitive tumors, particularly myeloma lymphoma. For radiosensitive tumors with high-grade cord compression, breast and prostate, with high-grade cord compression and myelopathy, you're not going to decompress them quickly enough with radiation. So if they have high-grade cord compression without myelopathy, we do conventional radiation often, or hypofractionated radiation. But if they're myelopathic breast prostate, take them. For radio-resistant tumors with minimal node spinal cord compression, radiosurgery, and again, we're now starting to transition to high-grade cord compression with 3-fraction radiation. And for radio-resistant tumors with high-grade cord compression, particularly with myelopathy or cauda equina syndrome, separation surgery followed by radiosurgery. If they're unstable, fracture-related pain, it's a separate assessment. Those patients are candidates for kyphovertebroplasty, per screws, open surgery, these percutaneous ablations, et cetera. And then everything is predicated on what they can tolerate from a systemic disease standpoint. This field is evolving so quickly and it continues to evolve. And so what I'm hoping with the radiation oncologists and the surgeons here is that we can get you interested in continuing to evolve what we know. In the surgery, as we talked a lot about, is we're trying to get as minimally invasive as possible with these patients. We did develop a very large NF program, which was interesting. It was really predicated on the use of Da Vinci robot for paraspinal schwannomas, and it's really been a gift for those patients. They do go home in a day with better resection than we used to get in the open surgery. For radiation, we are still working a lot on radiosurgery, but proton beam is sort of the new iteration, and proton beam is coming here really soon. We have a case series now that we'll put out in the next hopefully 2 or 3 weeks of hypofractionated protons, so 30 gray and 3 in 50 patients for recurrent tumor. Because Josh Yamada, my radiation partner, was a brachytherapist, for a long time we had a P32 dural plaque that we used fairly liberally, and then it got pulled from the market. So we're now looking at a different beta emitter, cesium, again, to clear dural margins, has very high dose delivery with almost no penetrance. We've written a lot of clinical papers based on this experience that we've had, a little over 250 now. And the newest iteration is looking at financial toxicity and price transparency. We have a number of prospective trials, again, often integrating biologic checkpoint inhibitors with radiation, and then an enormous effort in translational research looking at mechanisms of radioresistance, and then the genomics associated with tumor metastases. And with that, I thank you, and we'll take any questions.
Thank you very much, Dr. Bilsky. Any questions to start?
Should be pretty clear.
I think that was a great talk. I really appreciate you. You know, that certainly is a career's worth of work in that short period of time, talking to us about that. And I think, you know, it's interesting, you know, to hear your comments, and we talked about this before, just the resistance to treating chordomas without the surgery. And I'd like to hear your thoughts on why you think that might be, and, you know, maybe where the world might change over time.
Yeah, I think there was a period in time where these techniques of en bloc were developed and it was meaningful. We didn't have adjuvant therapy that was meaningful. And so all of that data sort of stands the test of time before you get ablative radiation. And that ablative radiation, really the initial studies were done in the 1990s with protons from Norbert Lieb's group. They published early on about how radiosensitive it could be. But then you started to get the studies that came out of Japan with carbon ions. And then our SBRT data has been around, you know, for 10 or 15 years. If you are an en bloc surgeon, it is a tour de force, and it defines a surgeon's talent to be able to take these out. The question is, why didn't they look at the radiation data? And even when we went to the Chordoma Foundation meeting that presented that algorithm, there was a massive attempt to keep out the newest radiation data, which is infinitely better than en bloc data alone. And I think it's just a matter of, you've defined a career around these beautiful pictures and defining how to take these tumors out. And then it's hard to just let go of that. It is an ego thing, I think, as much as anything. they're coming around a little bit. I think the thing that was so striking to me is that the orthopedists who mostly did the sacral tumors, Zia and Larry, they do a lot, but not in comparison to Pete Rose and Pat Bolin. And they published a paper from the Sacral Spine Society, Sacral Tumor Society, which was mostly chordoma. It was a chordoma paper in 193 patients. And they had 10-year follow-up data. And at 10 years, en-bloc resection for chordoma had a 27% local tumor control. And that was the data that shifted their opinion. And so Pete Rose was probably the most aggressive sacral surgeon I've ever seen. And they would take out sacrum piriformis gluteus, trying to get that microscopic penumbra that's ubiquitous in chordoma. And I saw him in a meeting, we don't operate on chordoma anymore. We have proton beam. The outcomes are significantly better, less morbidity. Stefano Boriani defined the WBB classification for how to en-bloc resect. He doesn't take out chordoma, they use carbon ions. We like photons a lot, but photons were much later to the party in terms of chordoma. And so the data wasn't as mature, but it is now. We have 6-7 year data median in all of the institutions that are using it. And so we'll get this data out in the next, and again, that it's hard not to move the needle at that point, but I think it's just been a real ego boost in these, and the surgeries are tour de force. They're brilliant and they're meaningless at this point. Yeah.
I really appreciated your presentation. I thought the narrative was very cohesive, so thank you. I'm a medical student whose work is mainly outside of oncology, so my question might be a little bit off. The data and the outcome that you presented, I saw is, it's beautiful, and it seemed to be mostly in adults. I'm wondering, in the pediatric spinal tumor populations, do you still apply the known framework in a similar order, or do you flip it and consider the systemic aspect beforehand, or how do you think through that?
Yeah, so most of the the pediatric are mostly primary. It's still the same framework, right? Because you still have to have the same considerations of how are you going to control the tumor? Are they stable or unstable? And do they have cord compression, or how are you going to decompress them? What changed, though, again, is super interesting, right? So we had an aneurysmal bone cyst that was not resectable. It was, they had a Damquitz feeder. It had been resected previously and had a really early recurrence. And so we went to medical oncology and said, what do you have? And they said, there's 2 case reports out of Europe using denosumab for ABC. And we didn't really have a choice. We put her on denosumab. It calcified into the small mass. It took us a half hour to take it out. And now we're using denosumab even for ABCs as definitive therapy in unresectable ABC. And it seems to be durable. We'll treat them for a year and then take them off. Giant cell, same thing. The rest of the pediatric tumors, you look at osteogenic or Ewing's or neuroblastoma, they really were medical from the beginning. And so they all get neoadjuvant chemotherapy. The difference now is because proton beam is so readily available, and it's a great strategy, obviously, in kids not to irradiate structures past the spine, that we have the leeway, again, to pare down the surgery. So usually you would give neoadjuvant, you would get a good response. You would take out oftentimes en bloc, but probably not necessary for most of them, especially if you got a good response. And if you have a positive margin now, you can do proton beam radiation. So the integration of radiation, even for the pediatric tumors, has changed significantly with the availability of protons. So
Thank you.
yeah, thank you.
By the way, your microphones will work. Just tap on them.
Yeah.
We'll see if this works. Yeah. I'm really interested in the imaging that you guys do, help plan your radiation. One of the challenges that we have is, as you mentioned, the placement of the titanium structures. We've talked a little bit about carbon. Do you guys do routine CT myelograms, or how do you approach that?
We do. I think, I don't know this we do myelo CT, and we do it even for non-instrumented cases. And we did it based on really the proton beam protocol when we started. And so they always did it for their patients that were, not spinal cord tumors. And so we just took that paradigm. And so we still do it a lot. I think the problem with MRCT fusion images and trying to define the cord is that they're pulling the OAR, the organ at risk, they're pulling that wider to account for the uncertainty in that fusion image. And I'm not sure that we're not going to end up underdosing at the margin of the cord. And I'm not sure that, and Josh says we aren't. So we are doing some of that now, especially for the network sites. So they could, but I'm not sure that we're not underdosing to some degree. And so we're pretty wedded to MyoCT still. He can better answer that than I am. He's so much more than that. But I think we may pay a little price for that. Maybe it's not a big price, but yeah.
With such a robust, I think, and multidisciplinary spine service, have you guys looked at time from separation surgery to starting radiosurgery and found like there's a minimum time we should wait or too long to wait?
So we don't think there's a penalty for going as early as you want, as long as you can sort of spare the operative corridor with your beam trajectories. We got to so what we typically do is sim them. They get their MyoCT 2 to 3 days after surgery. They go home for the treatment, home, and then treatment plans. And they usually come back within 10 to 20 days. And by the time they come back to clinic, we usually take out 6 to 3 weeks. They're usually done with the radiation. So we try to get them within that 3-week window to radiation. The problem if you don't get them simmed is you're gonna lose them and they're not gonna come back. They're gonna have some other complication or some other, Duke wrote a series, I think, or Vanderbilt wrote a series, one of the two, where 60% of their patients never came back for radiation. We're going to look at our hit rate, but we think it's probably closer to 5 to 10%. So, having them set up for the radiation even before they leave is super helpful. And then, with protons, there is a penalty because 30% of that dose goes to target. And then, you get this massive wound issue just because all the beams are brought into the same corridor. But with IMRT, it really, our wound dehiscence rate right now, post-op with surgery followed by IMRT is about 2 to 3%. It's incredibly low. But it's because you can spare the operative cord. Yeah. In fact, we wrote a series with pre-op radiation, which is really a bad one. There's that paper that if you're within 6 weeks of radiation then had to go to surgery, there was a 50% risk of wound dehiscence. There's an old Harvard paper. Ours was 6%. Yeah.
It speaks to having you guys involved with the contouring as well.
I mean, they're so good at it. They actually don't need us, but yeah, it's yeah.
I'm wondering if you'd be able to maybe speak briefly about, do you have a general approach to patients who've had prior radiation? So prior conventional external beam or prior radiosurgery, or is it just too patient-specific scenario?
No, I mean, failed radiation in our initial series of surgery, it was actually incredibly low. It was like 50%. In general, reirradiation, they like to wait 6 months from prior radiation to reirradiation. But if we don't have a choice, they'll go much earlier. They may just, put a bigger dose constraint on the cord, considering. But I think, at a year, I think there's probably goes back to a baseline risk that's pretty much zero is kind of the conventional wisdom. But we'll take them at 6 months with normal constraints on the cord. Is that the answer to the question or no?
Sure, if it changes your thoughts at all about surgery,
no on that no time of
the paradigm that you have someone with prior radiation, does that
For surgery or for re-radiation?
for both, surgery as well?
No, I'll tell you, if we fail radiation and we know and we still have a target for radiation, they just change the dose strategy and do it again without surgery. Because again, you at least conceptually, I don't think surgery has any bearing on tumor control at all. I think it's all about the radiation response. And so now at reirradiation, a lot of times we'll go to protons with a different dose strategy, or if they failed, 9 times 3, we'll go to, sometimes we'll do 10 times 5, we'll change the dose strategy, but try to get a big dose in. to that area. And again, Josh can speak better than I am, but I think conceptually, the surgeons have a big responsibility in this, but it now is all shifted towards, how effective radiation can be. It's good for us because we used to be like, they blame us for tumor recurrence. It's like, it's Josh. It's like, I had nothing to do with it.
Okay, well, thank
Right.
you
I
very
hope this was
much. Really
meaningful. Thank you
appreciate
guys
it.
so much.
Why don't we take a 5-minute comfort break, then come back. We'll do some cases with both the radiation oncology crew and our surgical residents, and just make sure to come back.